Okay, so this is where we left off. We'll finish up on the section of treatments. We're going to move into endocrine.
Yeah. Oh,
All right? Questions before we get going? You guys ready? So cancer's actually come a large way. Probably in the last decade have been some of the biggest gains within oncology. And it gives our patients an awful lot of encouragement, and families a lot of encouragement. I'm not going to stand up here and tell you that it always works. In fact, the numbers are staggeringly low. But when you think of doing nothing and the opportunity that some people are responding, that's the encouraging piece. So if you look up, cancer survival rates, and you look at different types of therapies and whether or not they're successful or not, you got to keep in mind that as the numbers continue to grow, that means that more and more patients are benefiting. So you got to keep it in perspective. So we're going to talk about a couple of different treatments, and we're talking about surgical removal, chemotherapy, targeted chemotherapy, and then immunotherapy. And really, for the most part, surgical removal and chemotherapy were all that was on the scene for many, many, many years. And surgical removal is exactly that, where if it's operable and the cancer is confined enough, and maybe you catch it early enough, you have an opportunity to surgically resect and take out the lesion, the cancerous mass. And inevitably what they'll want to do is try to resect out margin, or healthy margin as they call it, that's quote unquote non-cancerous, but just to make sure that you've gotten everything. Okay, so that's pretty straightforward on surgical removal. There are certain cancers that are not operable, or they're inoperable because of where they're located. Many situations, like with brain cancer, they're not operable, depending upon what type of cancer it is. We'll look at some tumor masses in our endocrine section in the next lectures, and we'll talk about different lesions that are more benign, and so they have nicely defined borders, and so they're easily operable, right? So if you've got a benign lesion and it has nice defined edges, then the surgeon can come in and say, well, let's go ahead and take 2 centimeters of healthy margin and we'll remove all of that. Well, in brain cancer, if you've got something known as glioblastoma, this lesion is going to kind of look like this. Makes it a little bit more complicated operating. And glioblastoma, which is highly malignant, doesn't have a very favorable success rate as far as beating cancer. And this is the type of cancer that Senator John McCain passed away from. Okay? So an operable lesion, which would be nice to see, versus an inoperable lesion. So then we go into other types of therapies like chemotherapy. So chemotherapy, and this is a classic one, there's literally, I don't know if there's 100 different chemotherapy agents, but there's got to be multiple dozens, okay? And every so often, a drug manufacturer is finding a new chemotherapy or a chemical drug. That's what it's called. Chemotherapy just refers to chemical therapy. And this is a drug that's a treatment that uses powerful chemicals. It doesn't use, sorry about that misspelling right there. It uses powerful chemicals to kill or destroy fast replicating cells. So cancer would be considered a fast replicating cell. It's replicating outside of the cell cycle controls. Well, some of the side effects of chemotherapy is you feel crummy, okay? You lose your hair, because the fast replicating cells that are hair follicles are also targeted, because this is non-specific. And then the intestinal lining is also targeted, because it's a highly turnover tissue. And so you have a lot of malaise or general ill feeling as a result of chemotherapy. Not to mention you're putting a poison into your body. So that kind of sucks, okay? So the side effects of chemotherapy, like 5-fluorouracil or cisplatin, have driven technologists to come up with alternative solutions, because these are not where we want to stop. Does that make sense? So many of you have probably been familiar with family or friends that have had chemotherapy, and they can only take it for so long, and then they're like, I need a break, okay? And the idea is that the chemotherapy agent is going to kill the cancer cells faster than it kills your own cells, your healthy cells. Then we get into the category of more sophisticated drugs like targeted chemotherapy. Targeted chemotherapy is actually pretty new. In targeted chemotherapy, where these cancer therapies block the growth and spread of cancer without, by interfering with specific molecular targets. So remember when we looked at those tumor markers? So for example, look at HER2. And who can tell me what HER2 is all about? What does it stand for? What do we find it? How do we use it? Plasma membrane bound. Human epidermal growth factor receptor 2, right? Very good. Is it found only in breast tissue? No, but it's highly expressed in breast tissue. And if you have a cancer in breast tissue that's out of control, it's going to upregulate. So there's a drug known as Herceptin. Herceptin is the registered trade name of the chemical drug trastuzumab. And Herceptin is specifically targeting HER2 receptor cells. Okay, so you have a more targeted chemotherapy. Will you have side effects associated with HER2 expression in other tissues? Yeah. But it's not as global. It's not going to hit the entire body like a cisplatin or a fluorouracil. And again, there are now a few dozen different targeted chemotherapy examples. And that's how they work, is it's not just a broad poison. It targets some specific molecular target. For example, like what we learned, and I picked Herceptin because we talked about HER2. So Herceptin has been revolutionary in breast cancer treatment. It's changed the game. And a lot more women are in remission as a result of Herceptin and cousin drugs like Herceptin. Okay, and this is a very new development. Okay? All right, the last category is immunotherapy. So in immunotherapy, let's take a look at this diagram. Now that we know what the immune system does, we can actually excise the tumor mass or take a sample of the tumor mass, and we can actually isolate from the tumor T lymphocytes. So your immune system is going to respond to these tumors in some capacity, and you're going to develop lymphocytes that have specificity for that tumor. The problem is if the tumor mutates quickly, the lymphocytes can't keep up. If the tumor replicates fast and grows, the T lymphocytes can't harbor an immune response as quickly as it needs to be. So with an example of, and there's a lot of different immunotherapies, but one particular example, we isolate these tumor-infiltrating lymphocytes, or TILs, and we grow them up in the laboratory, and we expand them. We activate and expand them. The ones that have already discovered the tumor are the ones that we expand. And then we can actually transfer them back to the same patient. So they take the patient's own tumor, excise it, isolate lymphocytes that have found specificity to that tissue, expand them in culture outside of the lab, and then deliver them back to the patient. And now you've assisted the immune system to go target that tumor mass. Does that make sense? That, in a nutshell, is an example of immunotherapy. How you're leveraging the body's own immune system to go fight the cancer, but you're helping by augmenting it. Now, this one's also showing, in addition to the tumor infiltrating lymphocyte transfer, we actually will deliver a chemotherapy or a radiotherapy in combination with immunotherapy. So I didn't talk about radiotherapy, but radiation can be used to treat certain types of cancers. Why radiation? Well, it's destructive to cells. Not just is it destructive to your own cells that are healthy, it's destructive to tumor cells. So you can actually do radiotherapy that's very specific, or radiation therapy that's very specific and target that tumor mass. Okay, so that's not one I put on the slide, but I'm talking about it right now. Yeah, that's all I'm going to say about that. We can go off on tangents on different types of therapies. I'll give you one example. So in the battle, because I talked about the glioblastoma, at Barrow Neurological Institute, patients that actually have brain cancer, they'll use a lot of gamma radiation because they're not they may not be surgical candidates. And so with gamma radiation, they can focus that radiation beam, there's a technology called the gamma knife, and they can actually pinpoint with precision 3D accuracy, shining or illuminating radiation, exposing the brain tissue to radiation, but in a particular area. Okay, so we've gotten so sophisticated now with radiation therapy that we can actually treat lesions in the brain using gamma radiation, because we can map the brain and we can 3D direct the radiation to one particular location. You couldn't radiate the whole brain and kill the person, but if you can focus the radiation into a specific plane within the tissue, right? And usually it's pretty sophisticated. What they have to do is they actually surgically implant a 3D positioning cage on the patient's skull. So they screw it into the cranial cap. And then the radiation device uses these XYZ planes to figure out, using 3D reconstruction, exactly where in the brain this needs to be illuminated with radiation therapy. Okay? So different, kind of talk about 4 or 5, surgical removal, chemotherapy, targeted chemotherapy, immunotherapy, and then I kind of went off tangent and talked about radiation therapy because it's relevant to where we migrated in our conversation. So questions about, sort of the 5 different modalities of treating cancer today. It's pretty comprehensive. There might be there's a couple other, side ones that I didn't really talk about, but those are the main treatments. Yeah?
The mapping, the brain mapping device, is it like a stereotactic device?
Yeah, so it would be basically 3D MRI.
And so, yeah, that was my question, because like everyone's brain is different depending on their experiences and stuff. So would they have to, I guess they would have to use an MRI to make sure that the map is correct for your specific brain?
For sure. So what they'll do is they'll implant the cage, the patient goes into the MRI, he gets a 3D map of the brain with the lesion, and the XYZ of the cage is the reference point, and then they'll go in on that map and specifically target where the lesion was. It's quite impressive how far we've come. Yeah. Okay.